All right, we're back, everyone. So on to the next topic. So shock and multiple organ failure. So sorry, this one won't be as fun with videos, okay? So there's a lot more science behind this. So hope I don't put you to sleep with this, okay? But shock and multiple organ failure is another very high yield area. Let's start off with something if you're falling asleep here. You like guys like Gomer Blog? You get a lot of funny articles you can read. It's kind of like The Onion, right? PM&R doc shocked to find out he's been on call for 3 years straight. I can make fun of them because we're not PM&R. All right, what other types of shock is there? RN is shocked that the code isn't etched somewhere on the door frame. So true. All right, let's get serious now. So on to real shock. You've got a 22-year-old male lost a fight to John Wick and has sustained blunt abdominal trauma with splenic liver lacerations and an unstable pelvic fracture, BP 8/54, tachycardic after 2 liters of crystalloid. He is intubated due to declining mental status. He is taken emergently to the OR for an X-lab and an X-fix of his pelvis. Which is the best resuscitative strategy? So what would you do? Infuse another liter of crystalloid, infuse 500 cc's of 5% albumin, infuse PRBCs, then platelets and FFP based on the return of lab values, infusion of PRBCs, then platelets and FFP before return of lab values, infusion of PRBCs with vitamin K. It's a trick question because if you're fighting John Wick, you'd probably be dead. But anyways, the answer is infusion of blood, then platelets and FFP before return of lab values. And we're going to talk about all different types of shock during the next hour. So what is shock at its core? It's the inadequate delivery of oxygen and nutrients to maintain normal tissue and cellular function. Cellular injury is initially reversible unless prolonged. Blood pressure alone is an insensitive measure of shock. I think that's very important. We tend to kind of fall into this trap, especially clinically and on rounds, of just looking at your blood pressure and then saying, oh, someone's in shock. There's different types of shock. Initial insult of tissue hypoperfusion initiates a neuroendocrine and inflammatory mediator response. And of note for this lecture, I think that the board loves to ask a lot of the science behind inflammatory mediators and shock. So we're going to go over that today. Persistent hypoperfusion will then result in end organ dysfunction, cell death, and possible patient death. So one of those busy algorithm slides, but I think this one right here is going to be your take-home point. So you've got distributive shock on the far right, kind of like septic shock. And at the core of this, you've got an increase in cardiac output. Okay, just follow the algorithms down, and then you'll see it goes to decreased mean arterial pressures, shock, multi-organ dysfunction. And then you've got your other ones, which are lower, usually decrease in cardiac output. So hypovolemic shock due to decrease in preload, cardiogenic shock, like a myocardial infarction. And then you've got several different types of extracardiac obstructive shock. So something anatomically obstructing your flow, which would be tension pneumo, tamponade, causing decreased diastolic dysfunction, or you've got decrease in ventricular afterload, like a massive PE. So that's all kind of depending on where in your anatomy you have that obstruction. Don't worry, we'll go through them individually. So obstructive, impaired cardiac output caused by physical obstruction of blood flow. Cardiogenic, inadequate tissue perfusion from myocardial dysfunction. Hypovolemic, which is the one we're probably most used to talking about, from trauma. Inadequate tissue perfusion from blood loss. Distributive shock, inappropriate distribution of blood volume with inadequate imbalance of organ and tissue perfusion. So the physiological response to hypovolemia, we're going to preserve perfusion to our vital organs, the heart and the brain. So you're going to be vasoconstricting. You're going to be shifting fluids into the intravascular space. So you're going to increase in cardiac contractility, increase in peripheral vascular tone, just to get the blood back to where it needs to go. Hormonal response to preserve salt and volume. And we also have autoregulatory mechanisms to be able to keep this in check. So some equations that you're remembering and recalling back in your PGY2 ICU rotation days, which we need to know. Cardiac output is your mean arterial pressure minus your CVP divided by your SVR. So mean arterial pressure depends on your cardiac output and your systemic vascular resistance. And end organ vascular supply depends on the maintenance of BP within a defined range, and you have this concept of autoregulation. So here's autoregulation. You've got a range in your mean arterial pressure where your perfusion kind of maintains in a stable range. Then once you get beyond that, then you're going to have derangements causing differences in your organ perfusion. So autoregulation is failure to maintain minimum mean arterial pressure for autoregulation which is indicative of a severe reduction in cardiac output. So we want to be able to prevent this from coming to a point where now you have a reduction in cardiac output. We have microvascular function dysfunction. So you've got vasomotor dysfunction, endothelial cell dysfunction during shock. Question here, which of the following is a pro-inflammatory mediator of shock? IL-4, 6, 10, 13, prostaglandin E2, IL-6. So one of those things, you just remember it, memorize it. End organ beds are affected by vasodilating substances, so TNF-alpha, IL-1, vasoconstrictive substances such as catecholamines. You've also got adaptive mechanisms. You preserve your heart and your brain, and you have to sacrifice your other organs. With endothelial cell dysfunction, you get capillary leak, and that's due to free radicals building up due to shock, which are activated neutrophils like IL-6. You've got other vasoactive mediators, histamine, bradykinin, PAF, leukotrienes, TNF-alpha, IL-1, those acute phase reactants. Plasma protein loss will lead to hypovolemia, interstitial edema, and ARDS. So what ends up happening is you've developed cellular ischemia, you've increased the amount of inflammatory mediators throughout your body, free radical injury will then occur. And with regards to cellular ischemia, this hypoperfusion and ineffective perfusion will then lead to anaerobic metabolism. Your ATP demands increase relative to your ATP supply. So then you got sodium potassium pump failures, sodium water influx, your organelles swell, they rupture, then that leads to cell lysis and cell death. So this is kind of the biologic, back to your med school first year days of how these things work at a microscopic mechanism level. So that's just another kind of schematic of increase in lactate levels. You know, we always get called from the ER saying, oh, you've got a patient with a lactic acid of 4 or 5, and this is kind of the science behind this. Hopefully you're not having dreadful memories of the Krebs cycle. So a little bit more on inflammatory mediators, circulating or local TNF-alpha, IL-1, IL-6, myocardial depression, seen in sepsis, mediated by TNF-alpha and IL-1B. Nitric oxide, so you've got inducible nitric oxide synthetase, which can result in large amounts of NO production. Systemic vasodilation then occurs. You've got increase in free radical injury, so neutrophil activations, IL-6, IL-8. You've got superoxide anion to hydrogen peroxide to hydroxyl radicals that are formed, and these destroy lipid membranes, causing again cell lysis. So just another way of kind of summarizing all this, you can see at the end of the day, inadequate perfusion leads to cell hypoxia, losing energy, causing increase in lactic acid, leading to metabolic acidosis. Then your cells swell, altering your sodium potassium pumps, lysozymes release digestive enzymes, all leading to lysis. All right, so on to kind of shock, all the different types of shock. So let's start off with extracardiac obstructive shock. Characteristics, you've got obstruction to flow within the cardiac circuit. So you've got either impairment of diastolic filling or excessive afterload. So if you have impaired diastolic filling, think of where you are in your heart function anatomically, you've got direct venous obstruction. So what can cause venous obstruction? You've got increased intrathoracic pressure due to a tension pneumo, maybe mechanical ventilation can cause this, asthma with auto PEEP, decreased cardiac compliance, constrictive pericarditis, so an infection, cardiac tamponade. If you have systolic contraction that's impaired due to your right ventricle,